Hi everybody, Dr. Stuffluke here. We're going to talk about doing an induction to show you what my style of doing an induction is. Basic induction, healthy ASA1 patient. He's 33 years old, 70 kilos, no allergies. Going to have some sort of procedure done that we're going to want a muscle relaxant for and have a general anesthesia for. So this is how it looks for me. I will point out some things along the way that I want to make sure you incorporate, but at the end of the day, you may have a slightly different induction sequence than I do. Kelsey's going to be our nurse, and she is going to go ahead. Patient just comes in, and we're going to start hooking up. First thing I want to hook up is the blood pressure cuff, which is going off on us right now. All right, and I want to start that blood pressure going, which it is, because I want it to start cycling. I have it cycle every 3 minutes, okay? Minimum is every 5, but we're doing an induction, so we're expecting some swings in blood pressure, so I make it a little bit more frequent. ASA guidelines, AANA guidelines, remember minimum every 5 minutes. But I like to have it every 3, and then I like going back to the main screen. Kelsey hooked up our patient for the 5 lead. Remember your mnemonics for hooking this up in case the nurses don't hook your monitors up for you. I like smoke over fire, white is right, and snow over grass. And then of course your V lead, however you want to do this. You are going to remember your precordial stethoscope. I'm borrowing this one so it's not going to go in my ear. If you don't have two-sided tape, go ahead and put this on with a tape like such. I like the left side because if we intubate in main stem, it's going to be more times on the right than on the left. So I can hear decreased breath sounds and know that I'm most likely main stem. I can also hear heart sounds better on the left than I can on the right. So that's my preferred spot to put the precordial stethoscope. I do start listening as I induce. Now, sir, did that Versed affect you at all that I gave you in pre-op? A little bit? Okay, that's pretty good. I do need to get you some oxygen, so I want you to breathe this in. Just breathe normal for me. So remember to turn up high flow, 100% oxygen. Anything over 5 liters, so you might as well just crank it on the way up. I apologize, this smells like plastic. All right, just go ahead and breathe normal. We can either take our straps at this time to hold it on there, or we can say, Nurse Kelsey, could you please hold this on? Patients like this process better, but if you don't have the help, that strap is wonderful for you. So what's our goal? We're going to denitrogenate, right? You know, the books say 3 minutes or 3 deep breaths. We want our FRC, which is going to be our expired O2, to be 80% or greater. So as you see, we need a little bit of time. And we're going to let that build up as I start giving some more medications. What medications, you say? I do like to give my antiemetics at this point, so if I'm going to do that, I give them before I give my narcotics. So Zofran is one I always like to give. It's 4 milligrams. For the adult, it would be in 2 cc's, and you can't give it fast. So I will go ahead and I will give 1 cc. I like to give Decadron a lot, either 4 milligrams or 5 milligrams. So I go ahead and put it in that fast. Now I want a blunt laryngoscopy. I like to stay a little bit under 1 mic per kilo. So what we normally draw it up is 2 cc's, so that'd be 100 mics. I'm only going to give 50 for this patient. So I give 1 cc. All right, the medicine going in might make you get a little blurry-eyed, and that's okay. That's very normal. Now I go ahead, give the rest of my Zofran. So I gave it a little over a minute for that whole induction going in. I do like to give lidocaine. You can give 1 milligram per kilogram, but I go a little bit lower on this because I give other drugs for blunting laryngoscopy than just the lidocaine. So I would give 30 milligrams to this patient of lidocaine. And at this point, I'm going to go ahead and put my propofol and my rocuronium in line. I've already checked my endotracheal tube. I know that it's good to go. I have my airway set up, of course. Okay. I want you to start thinking what you're going to dream about. You get to dream about anything you want. I won't tell a single soul, okay? None of my monitors can tell what you dream about, all right? So this is the point that they usually smile at that, then you know what they're thinking about. So we're going to go ahead and put some medicine in. It might burn a little bit or feel a little warm. That is so normal. I'm going to go ahead and give propofol, 140 milligrams. Healthy individual. They can tolerate the 20% drop in blood pressure fairly well, so I'm going to give 2 milligrams per kilogram, that 140. And 140 is in. Okay. And you just keep breathing normal. You're going to go ahead and go to sleep for us. I'm going to be with you the whole time, not going to leave you at all, and I will see you when you wake up. His eyes is now closed, so I'm going to check the eyelid reflex. Nothing happens. There's no squinting or anything like that, so there's no reaction. So I know that he is unconscious. I'm going to go ahead, turn my APL valve from 0 up to higher, can be anywhere, 30, 40, 70, and I'm going to try to ventilate. I only know if I'm ventilating if I get end-tidal CO2. I got end-tidal CO2, so I know I can ventilate. If I did not get end-tidal CO2, I would throw an oral airway in, not try to readjust or anything. Go straight to that oral airway until you guys develop the skills of your masking skills. I know that I can ventilate the patient, so I'm going to go ahead and give 30 milligrams of rocuronium to this patient. And I look at my time when I got that. So I see 52, 54, so we'll say 53. I want at least 90 seconds. This is going to be a very long 90 seconds for you guys, all right? So I know I need 54:30 before I try to intubate. So I turn on my sevoflurane from 0% to 1%, and because that patient's not breathing, I go ahead and I keep breathing. Now remember, I put this in my ear before I pushed the propofol, so that way I knew and I'm listening as I induced and as I'm breathing here. So not only am I getting end-tidal CO2 here, I'm listening here. This is where you might want to start a conversation, because as you can see, I still got 45 seconds to go. I told you it was going to be a long 90 seconds. You guys looking forward to the weekend?
We are.
Yeah.
We could go through Mistmates.
No.
No.
I did that before the patient came in.
That's true.
That's true. All right, so I'm at 54:10. Right? So we're getting really close. What I want to do is I want to tape these eyes, because I'm going to start focusing on going for the cords. So I want to make sure that I do not give this patient a corneal abrasion. No corneal abrasions allowed, okay? Now, any of my movements, I'm not going to accidentally scratch their eyes, okay? So we have our 90 seconds in. I turn off my sevoflurane. I'm going to use a video laryngoscopy technique so that you guys can see what I'm doing here. I give the nurse the endotracheal tube to help get ready for me. 3 different ways that you can open the mouth. You can do the scissors technique, which is very assured. Thumb going down, finger coming up, nice big wide. You can just pull the chin down, or you can kind of position the head. Go in, tell your preceptor the way in what you are seeing. I see lips, I see teeth, I see tongue and hard palate, I see uvula, I see, well, we didn't really see the epiglottis now, did we guys? Okay, so we see the cords. And I asked Kelsey, and she gave me the endotracheal tube, and I'm gonna go through the cords. See that nice black line? That's what I want sitting right through the cords. So I put the black line right up through the cords. I ask for the stylet to come out. It comes out. As you see, I have the grip of death here. My fingers are on the patient. They've been on the whole time. I am not moving this endotracheal tube, okay? Adults are usually 19 centimeters to 21 centimeters at the lip. This one is about 18, but you saw that I had all the dirty stuff comes right by me. or the nurses might take it away, which is all good. We're gonna hook up. Remember, we give ourselves, we need to be able to do this all within the amount of time we can hold our breath. Even though our FRC is nice and full, so we know they can go about 8 minutes. Switched my hand to death. I need to blow up that balloon. Now, you're generally only going to need 5 or so on a real human being. Our mannequin, it just takes a whole bunch. Okay, I am going to ventilate. The beauty thing is I am listening already, but I'm looking for end tidal. That's my first and most important thing that I'm intubated. I have end tidal. My second is now I check for breath sounds. I've already heard once I got breath sounds. That's pretty awesome, right? So now I'm going to take a stethoscope, which you're always going to have around your neck or ready to go, and I'm going to listen. I am going to listen to apices. Okay. I'm going to listen to the sides, and I'm going to listen over the stomach. Okay? If I did not have end tidal CO2 at the first part, I would listen to the stomach first with that first breath, right? I don't want to keep putting air into the stomach. I had end tidal CO2, our most important confirmation that we have this. So I heard equal breath sounds. I still never have let go of that endotracheal tube. I definitely want to give this patient some medicine to stay asleep, right? So let's go maybe 1 MAC, so 2% sevoflurane on this patient. I want to start the ventilator going. And I will have a separate video on how to set the ventilator, but I have this going. I hit confirm, and now I'm starting to ventilate for the patient. Got to turn these flows down, right? Now, high flows will get this on quick, but my propofol and stuff is still circulating, so I don't need this at high flows at this point. So I'm going to go down to whatever flows you put on your care plan. I'm a really low flow person. Notice I haven't let go, right? I'm still holding the patient. I'm still holding this. This ain't going anywhere, so I tape it. And we can do a taping video for you guys too. This is not the best tape. Kelsey, can you hold the tube for me?
Yep.
Right there. Okay. So I have somebody help me. I'm going to be honest, in real life, I have my tube tree do all the helping, and I do a lot of stuff myself. So I have 1-inch tape, tore it in half for 1/2 inch each way. That goes on the corner of the mouth. I always go on the maxilla, right? The mandible moves, so that's not a good place to tape to. I want to tape to where it's not going to move. And now, because I knew that it was 18 at the lip, right? 18 at the lip. I checked that after I had bilateral breath sounds, so I tape it right at 18 at the lip. Okay? I can take out my precordial out of my ear and either keep it hooked to however you guys have it, or I can just have it by the patient, okay? Because I don't want to clothesline myself. But now I'm going to listen to that every 15 minutes. Surgeon, you can go whenever you please. I have the patient asleep, okay? So now they will start doing all their stuff. We'll do a timeout. We'll make sure that we're going to give antibiotics at this point, before the timeout, before incision. And I can look at my blood pressure, look at my heart rate. What do I have to, do for this patient? And then basically clean up and all that good stuff. That is our induction.